Welcome. This is Charles Denham with Texas Medical Institute of Technology. We'd like to welcome you to the Critical Reporting Issues for Quality Leaders. It's one of our series of the High Performer webinars. We have a really terrific lineup, so I'll move quickly into our webinar. I do want to remind everyone, now I'm on slide 3, just to turn the volume up on your computer, and if you have problems after you turn up the audio on your computer, you may click down on the lower left-hand corner on Request Phone, and then our staff can help you with another direct line. Next slide is slide 4. If you have not downloaded the slides, please go to www.safetyleaders.org, and as you'll see up in the upper right-hand corner of our landing page, you can click on the webinar, and this will also be where you go back afterwards to be able to download a written transcript that is word searchable, and also be able to listen to the webinar and watch it. I am on slide 6. Slide 5, and really addressing where that might be found, and you'll be able to download a number of resources that we've provided for you as well. On slide 6, we have our Twitter and Facebook coordinates, so please take advantage of that as well. We'd like to thank Regina Holliday, our TMIT fellow, who's helping us with social media. On slide 7, again, our mission is to save lives, save money, and build value in the communities we serve, and this reporting topic, I think, is really a terrific one for us to keep focusing on. Most of the people and most pilots would say that our leaders are in a helmet fire. There's just so much about reporting that is just coming in over the transom, and I think we've got some great leaders to help us a little bit with sorting some of the issues out and being aware of what is going on. We'll have further, deeper dives in this topic all year long. We're really thrilled to have our partner in a lot of the work we do, Sully Sullenberger, John Nance, both aviation experts, David Klassen, well known to the patient safety and quality community around the world. Arjun Srinivasan is a leader at CDC, and Paul Malpidi, his colleague, will be presenting, and Jennifer Digman representing our patients and families, and Frank Giotto from our team. I won't read our disclosure statement, which is on slide 9. However, no funder or educational grantor has had any impact on this presentation. We always start with the voice of the patient and family. This is not tokenism. Jenny Dingman has been a long-standing supporter of our work nationally and now globally. She is a public speaker. You can find her on SpeakerLink. She's also a published author in the space of patient safety, and I think she's most known for being a wonderful ardent supporter of all things patient safety and a real champion servant leader behind the scenes. Jenny, would you please lead us off?
Yes, good morning and afternoon to everyone, and I just really want to thank you all for being here today. This is going to be a wonderful webinar. We have great speakers, and I just wanted to thank you for all of the patients and families in the United States whose lives are going to be affected by what you're going to learn here today, and all of your hard work and your passion for patient safety. Thank you so much. Chuck?
Thank you, Jenny. And Jenny, we'll have Jenny be reacting as part of our reactor panel as well. Slide 12, we address our Greenlight program, and you can find it on safetyleaders.org. We have a number of hospitals on high-performance collaboratives, and our focus is to help us get the green light in the boardroom to fund and sustain patient safety and quality initiatives. Slide 13, I just want to remind everyone on this webinar that instead of the third Thursday of the month, next month, April 27th, we will have a global webinar. We'll be broadcasting and streaming from 10 o'clock East Coast time to 4 o'clock East Coast time globally, reaching Europe and emerging nations as well. We have representation from the World Health Organization, as well as great leaders that are on this webinar. I think almost everyone on this webinar will be involved in one way or another as a speaker or a participant, and we're really thrilled to have that the day of the premiere of our next Discovery movie, which is entitled Surfing the Healthcare Tsunami, Bring Your Best Board. This is a call to action to communities and patient safety and quality to rally around where ground zero is, and we have put in our recent article on it, the NTSB for Healthcare, that ground zero is the boardroom. So this will be the premiere of the movie in Washington. There'll be one and there'll be more to follow. There'll be one on the 3rd of May in Austin, Texas at the Bass Concert Hall, at Harvard on the 15th of May, along with the Brigham and Women's Hospital. We'll have one in Maui, and then later that month in May, and then in June one in Los Angeles. And you can watch the trailer on our website. Finally, a program that we're launching through the Green Light program is the 5 rights of imaging to make sure that we get the right study, right order, right way, right report, and right action. And you can find more on the website about that. And then finally, you can watch the trailer of this upcoming movie if you go to safetyleaders.org. And each of the speakers that you now see on slide 17 are in that movie. We have Sully Sullenberger and his landing on the Hudson, and the aviation crossover issues. We have David Klassen representing the wonderful expertise that he has in multiple areas. John Nance, who's on this webinar today as well, representing the crossover of aviation and leadership, a best-selling author, pilot, lawyer. John is truly the Renaissance man, and I get to narrate this wonderful group. So just to set up our discussion, I'd like to draw your attention on slide 18 to the Health IT and Patient Safety Report that Dr. Klassen will address in more detail. You may download the executive summary from our website at the same place where you got the slides, as well as the executive summary. And we'll ask Dr. Klassen to really address this issue of the fact that safety is a system property, and this concept of a socio-technical system. And so we'll allow him, this slide will come up again in the deck and cover it. My job is really to kind of remind us that in both the press as well as our scientific literature, we have irrefutable evidence of the system failures. Our safety net is failing. We are now facing huge cuts in reimbursement that is only going to make that worse if we don't take a stand in the boardroom and really focus on those issues. We'll have more to follow in more webinars. Just a reminder of the OIG report, the New England Journal of Medicine report, as well on patient safety and the impact in one state, and the Health Affairs report as well in terms of improvement. 15,000 Medicare beneficiaries die per month. The global trigger tool was used, and Dr. Klassen will address that as well. So to introduce the topic of the aviation crossover, and specifically the issue of an NTSB for healthcare, whether it's an agency or a public-private partnership or purely private, in our article that we addressed that this is a critical need and that people are shocked without it. Recommendation 8 of the IOM report actually specifically calls for such an entity, and this next slide, on slide 23, I'll have Dr. Klassen explain in more detail, comes up again regarding reporting, collecting, aggregating, analyzing, and investigating, as well as disclosing events. And we know in our recent ARC report regarding culture that distrust is a major issue and reporting is a major, major problem. Sully Sullenberger, a wonderful partner of ours, who actually has his second book coming out now, which you can order on Amazon, Making a Difference, has been a huge partner in patient safety. Most people don't realize that he has formal training in safety and performance, and that he was the ideal guy to be piloting the U.S. air flight when he did. And Sully couldn't be with us today, but he is dedicated to the safety movement. We'll be at our summit and is a featured character in our movie, and I'd like to play that audio of Sully now as a setup to a deeper dive with John Nance. Kyle, would you please play? Sully, thank you very much for helping us with this webinar. Your dedication is just amazing, and your contribution is even greater. You were surprised, and most consumers are surprised, that there isn't an NTSB for healthcare.
It is surprising. In fact, it's shocking that so many of the things that we take for granted in other domains, particularly in commercial aviation, have yet to reach common practice in medicine, and that has to change.
You were pleased, as were we, John Nance and Dennis Quaid, our other co-authors, Jim Bajan, our fifth author in the next article, that the Institute of Medicine really focused on an NTSB for healthcare. Are you pleased to see that Congress will get that report?
Absolutely. You know, in aviation, we also are an evidence-based domain. We do root cause analysis. We have a formal lessons learned process where the results are widely disseminated but locally actionable. We also have, which is very important, a nationwide aviation safety reporting system using de-identified data that forms this vast amount of they can mine to look for trends.
Sully, we, in our upcoming movie, Surfing the Healthcare Tsunami, Bring Your Best Board, we say that the boardroom is ground zero, not the bedside. The same for aviation?
Absolutely. In fact, when I testified before the House Aviation Subcommittee in February 2009, the then committee chairman, James Oberstar, said, safety begins in the boardroom, and I couldn't agree more.
The allocation of resources to and the attention on the invisible safety net of leadership, practices, and technologies, the same for healthcare as it is in aviation?
Absolutely, and leadership is the key. Leadership sets the tone, creates core values that have to be demonstrated every day in a very coherent and authentic manner. But it also requires the engagement of the frontline workers. And it's also important that supervisors be mentors and not just administrators or disciplinarians.
Today on our webinar, we have many of our great quality leaders and safety leaders across America. They really are the bridge between the front line and the mid-level managers in the boardroom. Do you think it's proper for them to really get training and helpful for them to get training to communicate safety issues in boardroom speak?
Yes, and they hold the key to making this change real. They are the ones able to connect the dots. And, of course, leadership must set the tone, provide the resources and the commitment. But it's the individual employees who have to make it happen every day, consistently, and apply best practices in every case.
We describe in the upcoming movie that aviation, auto racing, and healthcare are high-performance activities in a high-risk environment, but these threads of this invisible safety net are there. You have helped us understand what aviation has done to dramatically reduce mortalities. Do you think we can apply these principles to healthcare with good reporting?
Yes, and it shouldn't be surprising to us that there are so many similarities across domains, because what we're talking about is just what you said, human performance in complicated systems that involve inherent risk. And what we have to have is a robust safety system in which we can all operate, where errors are expected to happen, they're trapped, they're corrected in a timely fashion, where we have leaders who build teams, and we are able to accomplish as a team things that we cannot accomplish as individuals. And we also create a shared sense of responsibility for the outcome.
So the Journal of Patient Safety has just been an absolutely terrific supporter of progressive initiatives that we've launched through and with the journal. We'll have, at the end of this slide deck, there's a slide that Frank Giotto will put up that addresses a number of special issues that we'll have forthcoming. And one of them addresses the board of directors, but there are a number that address payers and up and down the performance system. One of the issues that we've addressed, and it's in one of the articles that may be downloaded, is an editorial I wrote regarding where the journal is going to go, and one is to reach out across the boundaries of industry to other industries. And it's our belief, Sully Sullenberger, Dennis Quaid, John Nance, Jim Bajan, and I, and Jim Bajan will be a co-author of the second part of this article, that we have just barely touched the surface of what we can learn from aviation and how they dealt with their tsunami of risk and harm. And this is really a setup to John Nance, who is truly an expert with that crossover know-how and knowledge. This slide number 27 is the cover of what is called a blue cover report. All four of us are jet pilots. Dennis Quaid and I roughly have about the same hours. I have more hours in a jet than he does, but we both have about the same number of hours flying everything from aerobatic biplanes to jets, but privately. Sully and John Nance together collectively have over 30,000 hours, cockpit hours, and all of us read these reports called a blue cover report when accidents occur. These are standardized reports that are blinded, that offer a multi-cause analysis of accidents, and had we had these in healthcare, we feel very sure that many accidents would not have happened. Inside Sullys Report, slide number 28, it addresses what were contributed to the survivability of the accident and the safety issues that were discussed. You'll find in the movie that we have in an upcoming article also that is by the same name, Surfing the Healthcare Tsunami, Bring Your Best Board, how to apply many of the aviation principles of leadership, practices, and technologies as a crossover. So as an introduction to John Nance, John really needs no introduction. However, if we were to read his bio, we would burn up his 5 minutes because he is one of the most talented, giving, and dedicated individuals to safety that I've ever met. He was with me last weekend planning for this upcoming event that we have in Washington, D.C., and has a new book coming out. His last book, Why Hospitals Should Fly, is terrific. I give it to every CEO I meet, and his next book we'll probably showcase in a future webinar. But John, we'd like to have you take it away. We put a slide up regarding, I know you're an Air Force guy, and I was brought up in Air Force bases, but the naval aviation mishap rate is a very good example as we lead into your concept of a red cover report. So I advance to slide 30 and turn things over for about 4 minutes or 4 or 5 minutes to John Nance. John, take it away.
Thank you, Chuck. First of all, you can always tell the difference between an Air Force pilot and a Navy pilot because the Air Force pilot likes his air bases to remain exactly where we leave them. Otherwise, we have to say the Navy got it right a long time before we did. The mishap rate in the Navy came down precipitously when they realized, among other things, that they had to invest the front lines with the authority to stop everything and to report in ways that people were eager to do because they saw the results of it, or that when they reported something, they were put up on a pedestal. We haven't learned that in healthcare. We didn't learn it as quickly in aviation or even in the Air Force. But one of the questions here, whenever we have a situation involving reporting, it has to be a core value, and the core value has to be based on not only the methodologies, which is what we're addressing with this idea of a medical version of the National Transportation Safety Board, but it also has to have the will. When we're talking about the methodologies, though, one of the things that has been a pet of mine for a very long time is the idea that we have no methodology in healthcare of spotlighting in a very intellectually rigorous way the need for taking certain occurrences, not all of them, but certain occurrences, especially ones that might be going on over and over again that we're not learning from, and analyzing them the same way the National Transportation Safety Board learned over time to do so. Now, this is, I mentioned the phrase intellectual rigor. It's actually beyond that. It's a methodology that's very straightforward in which you do not care about blame. Blame plays no role whatsoever in the analysis. What you're looking at is a statement of what happened, an analysis of all the facts, an analysis of the different causal factors, always with the idea in mind that there's never ever just one cause to a medical mishap, an aviation mishap, or an industrial mishap involving human beings. There's always multiplicities of causes, and every one of them is important. And then recommendations. We have no such form today, and the promulgation of something like this, certainly under the auspices of a medical safety board, would be of immense value because it would end up being the sort of thing, I think, fully that we have recognized in aviation as being personally invaluable as well as professionally. When you throw up a bunch of what we call blue cover reports, which is the prototype for this that the National Transportation Safety Board issues after every major accident investigation, it just happens to be on blue cover. That's not a formal title. You throw a bunch of those into a pilot lounge, you best be prepared to jump back because we're going to dive on those things. And the reason is because we know that that contains information on things that somebody else did that got them in trouble or worse, and things that we don't want to repeat. So it becomes an invaluable lesson, not just something that we have to shove from the top down, from the board down, or from the C-suite. And that is one of the key elements of helping people in this industry get to the point of saying our core value really is not just looking at safety and talking about safety and putting methodologies in place which are, shall we say, tactical versus strategic, but actually having a methodology of sharing this information and letting it go far and wide. I am very enthusiastic about the possibility of getting this on, getting this to start, because in terms of reporting, you really have to have a baseline of understanding of the things that are the most important elements. And you know, everybody on the line here on the webinar certainly is aware that number one on the hit list of the Joint Commission for a long, long time now has been something as simple as getting rid of undiluted potassium chloride on the units. But it took probably 10 to 15 years of killing people wholesale, of getting undiluted KCl into a syringe, when that wasn't anticipated to be, that wasn't, in other words, what people were trying to do, before they finally even came out with that request. With a reporting system like this, that kind of an accident could be literally spread across the spectrum of healthcare, and not just in the United States, but all over the world. So my method here, underlying the madness of wanting to do something that aviation has done, is that intellectually, as well as operationally and certainly strategically, this is one of the most important steps we could take in helping to make a standard methodology of approach, helping to make it intellectually rigorous, helping to get everybody away from the blame culture and understanding why it's so important to never look at just one cause.
Well, thank you very much, John, and we'll be coming back to you in the interactive session here to take a deeper dive, and we will be discussing this issue in the upcoming summit, and Dr. Klassen, Dr. David Bates, Dr. David Hunt from the Office of the National Coordinator, likely representation from the IOM, and then comments from our audience will be coming in regarding this issue. Again, people are so concerned that we're going to recommend starting some new agency that will increase taxes. I think it's really important that people realize that the NTSB costs 25 cents per citizen in America today, and that a healthcare national safety board would be a fraction of that, because all the methodologies have been baked. We've got the best practices and an infrastructure already. So at something less than a quarter per citizen, when we have 35 to 50% waste of $2.8 trillion, does not seem like an excessive cost. I'd like to now introduce Dr. David Klassen, and I always think of David as one of the unsung heroes of healthcare. I can remember when the trigger tool that he worked on at Intermountain Healthcare was something that he worked on during his master's, and he and I were quietly talking when we shouldn't have been, with Carol Harridan and a group of about 10 people in the mid-90s, and she asked us to say what we were talking about, and David piped up about this, and who would have guessed, without his passion and support, that the medication management trigger tool that had great success, now the global trigger tool would. But this is a multi-gifted contributor to healthcare behind the scenes. He's an infectious disease doctor. He was the real instrumental force behind the harmonization of the societies on the compendium for healthcare-associated infections, but also we worked very closely with him on the CPOE flight simulator and really all things safety and quality. He's now the new CMIO for Pascal Metrics, and a very gifted fellow, and really deeply involved with the IOM. And David, we'd like you to lead off with this concept of the socio-technical system, and then I'll advance the slides for you as we go through the deck. But thanks, David, for your continuing contribution.
Thanks, Chuck, so much for your gracious introduction. It's just an honor to be here. And I would encourage all of you to read the new IOM report on patient safety. It's the first major new report on patient safety from the Institute of Medicine in quite a while. You can either get it from Chuck's website at TMIT, or you can go to the IOM website. It summarizes, I think, where we are in patient safety, and then offers a model going forward. And that model that is offered here is represented on the slide, a socio-technical system. So we've talked a lot about systems for a long time in IOM reports. In this report, we get much more detailed about what that system would look like. We call it a socio-technical system. And clearly, as we look at the future of creating a much safer healthcare system, All these components are critical for achieving that, and when failures occur, it usually occurs in many of these components, not just one. So when we think of the role technology will play going forward, we really can't think of that role solely in terms of the silo alone. It must be thought of in terms of the larger socio-technical system. And to ensure the safe use of technology, we wrote an article published in the Journal of Patient Safety that's featured here that outlines how we might use an NTSB-like approach to assure the safety and safe use of electronic health record systems. Next slide. And in our IOM report, we do talk a lot about what it would take to create truly safer healthcare with the effective use of IT. We talk about the important role of all the members of the socio-technical system, and we talk about how this impacts not just the use of IT, but its design and development, and critically, its implementation. And we spend a lot of time in the IOM report talking about how we implement technology within the context of patient safety. Next slide, please. And we come back again and again to a landmark study that really changed the view of how we think about technology and safety. And that study really asked a very simple question. In organizations that have put complex electronic health record systems in with computerized physician order entry and clinical decision support, how good do those implemented systems do on a routine operational basis at picking up serious potential problems? So this study studied basically 62 hospitals who'd completely implemented these complex EMRs with CPO and decision support, and said, if we give them a series of problematic patient care situations, how many of these hospitals will pick these situations up? And these situations might be ordering a medication that a patient's deathly allergic to and seeing if the system picked it up, or ordering two medications together that together might kill someone. And what we found is in hospitals that put these systems in, enormous variability in how the operational systems picked up these potentially life-threatening problems. The best hospital picked up about 82% of them. The worst picked up only 10%. What was most chilling about this study is a subset of these situations were likely to kill a patient for sure. And of those subset of the total aspect of the test, only 53% of the time did operational systems pick them up. So that was a real eye-opener for us at the Institute of Medicine. Next slide. And led directly to one of our recommendations that moving forward in this socio-technical system, we can't afford to have complex dynamic systems that are not tested on a routine basis post-deployment. I mean, how often have you been in a hospital where the computer system crashes and has to be rebooted and brought back up again? Do we do any testing after the crash? Absolutely not. We just turn it back on again. Can you imagine being in a plane when a flight management system crashed and we just turned it back on again and didn't do any testing? So a key part of our Institute of Medicine report was that going forward in these complex systems, we need to test them on a routine, ongoing basis in operation to assure that they meet all the claims that the vendors made when they sold them to us. Next slide. And the test we could point to as the best example post-deployment testing of HIT systems is clearly the CPOE flight simulator that is outlined here. And about 450 U.S. hospitals have taken advantage of this. It's a free test that tests their system post-deployment. So that's what we pointed to in the Institute of Medicine report as an example. I would encourage all hospitals to avail themselves of this free test, because every place is taken and has their eyes opened about what's really going on in their system when they test it. It's one thing to accept the vendor assurances that, of course, you plug it in, turn it on, it works fine. That's really not the case. And we found some really serious safety problems with the use of this test. Next slide. I think the bottom line in our new Institute of Medicine report as we looked at the state of safety in the United States is that if you look at the most recent studies in safety and compare them to where we were in 1999 to the AIRS Human Report, we still have an awful lot of work to do to improve safety. Yes, we've made improvements in some areas, but for the most part, as this study outlines, we still have adverse events occurring in a third of the hospital patients at the very best hospitals and healthcare systems in the United States. And in our IOM report, we survey several other studies that suggest that despite all our efforts, an awful lot of harm is still occurring in inpatient hospitals. And this, I think, was a real important observation that if we think we've solved safety, we really haven't. We have a long way to go. And one of the other things in that article which was so critical is how we measure safety for reporting. And in that article, we compared the use of the global trigger tool in hospitals using external reviewers with those hospitals' voluntary reporting systems. And out of almost 400 adverse events that were detected in that study, only 4 were picked up by the hospital's voluntary reporting systems. And that was just stunning because all these hospitals were at complete electronic records in place. They had just push a button to report an incident and someone else looked into it. Only 4 out of 400. And that's the most common way hospitals measure safety. The other common method hospitals use to measure safety is using administrative codes such as the ARC-PSIs. And in this study, among those 3 exemplar hospitals that do a great job of coding, only 35 of 400 adverse events were picked up with ARC-PSIs. And I know a whole industry has grown out of voluntary reporting and out of the ARC-PSIs to measure safety. Together, they miss more than 90% of adverse events. That really influenced us at the Institute of Medicine to say we have to have a better way to detect and report. And I'll turn it back over to Chuck.
And David, I think that we'll be covering in a future webinar a deep dive on the ARC study that was recently released regarding that really captures the distrust of staffers. Over 600,000 staff of hospitals at over 1,110 hospitals were interviewed, and the majority felt that personal risk, if they were to report anything or if something was reported, that they bared personal risk. And one of the shocking elements was that 37% felt that they could not speak up if an error was happening. And so we have a crisis, or in fact a surge of distrust, which we will find we are addressing in the movie, and the issue of reporting is absolutely it's critical that we really take a socio-technical approach and understand the psychology behind blame and shame that still is just a terrible problem, and we don't have much improvement.
The only thing I would add to emphasize the point is we can use our current measurement systems, voluntary reporting and coding, to cover up huge problems in safety and to falsely reassure ourselves that we're getting safer.
Very, very important. And so these critical issues on reporting, we will be taking forth. What I'd like to do is now thank you, David, for a great overview. We're going to take a deep dive on the issues covered by Sully, John, David Klassen, the IOM report, reporting this issue of trust and distrust, the opportunity for leaders in the boardroom, where we have that socio-technical sort of approach envisioned, and break that down in this global broadcast that we'll have on April 27th. I'd like to now introduce our next 2 speakers who will address the update on the NHSN. Arjun Srinivasan has been a terrific partner with us in the Greenlight program and has spoken for us on webinars frequently, and at our last global summit that we broadcasted from the National Press Club in October of 2010. And Paul Malpidi, who will be the main speaker, and then Arjun, we know that you will be here for Q&A and also more dialogue. We'd like to introduce them to go ahead and take us forward. They lead this initiative, which is very exciting, and which is expanding across the nation, both in depth and breadth, and as we'll find, I think, future deliverables. Paul, would you like to lead us off?
Sure, actually. Thanks, Chuck. And like Chuck said, Arjun and I are here from the CDC. We're in the Division of Healthcare Quality Promotion, which is where CDC's National Healthcare Safety Network sits. And with this audience, we thought we would run through a little bit of background on where the National Healthcare Safety Network, or NHSN, is right now. And we don't want to focus on the public reporting aspects that you all might be familiar with. We'll touch on that, but we want to show you ways that you can leverage the information that's going into NHSN as part of our quality reporting programs for internal performance improvement. So just to show you that, when you look at this collection of headlines on this slide, this might be how you're most familiar with NHSN right now. In 2011, all facilities in the country that participate in CMS's inpatient prospective provider payment system had to start reporting central line-associated bloodstream infections to NHSN. That data will eventually be posted on Hospital Compare for public reporting. And in January of 2012, the first quarter's worth of data went up on Hospital Compare, which provided a fair amount of media attention. You can see on some of these headlines, hospitals now rated on infections, saying which hospitals were better performing than others. All these media headlines that came out are what we might think about when we think about NHSN right now in your positions. What we'd like to tell you is that NHSN isn't only about public reporting. We can use the information that we're putting into NHSN for different public reporting initiatives to improve our processes of care and performance and efforts towards prevention at the local level, which is what we'll try to focus on during our presentation here. Just a little bit of background in case you're not familiar with NHSN. NHSN is actually a web-based system. It's a secured internet-based system that keeps track of healthcare-associated infections reported by individual facilities, but as well as other adverse events and measures of processes. The users in the hospitals who tend to use the system are usually in the infection prevention realm, infection preventionists themselves, hospital epidemiologists. As more and more of this data is tied to CMS reimbursement initiatives, though, we have seen more and more quality staff becoming users in NHSN. Facilities are able to enter their data in NHSN, but perhaps more importantly, they can analyze their own data and also share data with other entities. When state health departments started public reporting of healthcare-associated infection data, they didn't want to have to create their own reporting system. So we built a feature into NHSN that allows these facilities to share relevant data with groups as they need. Data entry is traditionally manual, but we're moving towards electronic reporting, and I'll touch on that at the end because I know that's a hot topic issue for many people. We'll come back to that. And the point of NHSN is to combine our facility-level data about clinical performance and reporting infections with CDC's need to produce national public health surveillance data and also serve CMS's needs for their reimbursement programs. So we'll talk a little bit about where NHSN has come from and where it's going. This is kind of in reverse chronological order. Like I've alluded to, the inpatient prospective provider payment system is now acquiring reporting of data to NHSN in a pay-for-reporting structure that will eventually move to pay-for-performance. We'll come back to that. Recently, through the American Recovery and Reinvestment Act, or the stimulus package, funding was provided to state health departments to help them build capacity at the state level with all aspects of their healthcare-associated infection prevention programs, and part of that was building familiarity with NHSN. NHSN metrics were included in the Department of Health and Human Services Action Plan to Prevent AGIs, which was issued in 2009, is ongoing. The system has always been used for prevention collaboratives, where groups of facilities get together, implement interventions, and use outcome data they can get from NHSN to measure the impact of these interventions. Recently, also, we've seen a trend towards NHSN being used as the reporting system for mandatory reporting at the state level. But even since NHSN existed in its prior iteration called NIS, which some of you may or may not be familiar with, we have been around since the 70s for facilities to voluntarily report to and use data in NHSN for local quality improvement, which is a theme that we'll continue to touch on today. Just to give you an update on where we're at with NHSN in terms of reporting to state health departments, mandatory reporting of healthcare-associated infections to state health departments. Many states have reporting mandates. Not all of them are through NHSN. This is the most recent information for state health departments who have mandates to report healthcare-associated infections to them using the NHSN infrastructure. You can see the states across the top in increasing chronological order, most recently North Carolina and Indiana. And also on the slide, we've broken down the particular types of infections that are mandated to be reported, which does vary by state. All but one of the states require reporting of central line-associated bloodstream infection, or CLABSI. Many states also require reporting of surgical site infection, but which surgical procedures they're looking at does differ by state. There is increased interest in our multi-drug resistant and C. diff reporting tool. More and more states are requiring reporting through that. And you can see the smattering of other requirements by state. These state mandates, of course, link into discussing national de facto mandates or requirements for facilities who are participating in the CMS Inpatient Quality Reporting Program. Just to show you what those requirements were as of the end of last year, rulemaking is always ongoing. This is the most recent version that we have. As I mentioned, in January 2011, all acute care facilities that were participating in the program had to start reporting centralized associated bloodstream data from their adult, pediatric, and neonatal ICUs. And you can see on this slide there are more requirements that are going to be coming on as we go forward. At the beginning of this year, facilities that participate are now reporting catheter-associated urinary tract infections from their adult and pediatric ICUs, and also surgical site infections that occur after colon procedures and abdominal hysterectomy surgeries. We've also seen CMS expand the scope of the project outside the acute care setting. You see that in January, the rule took effect that outpatient dialysis facilities that participate in the quality reporting project with CMS have to use NHSN to report their dialysis events. You'll also see that later on in 2012, we'll be moving to other settings. Long-term acute care hospitals and inpatient rehabilitation facilities will start reporting CLABSI and CAUTI later this year. Next year, we'll start reporting facility-wide data using NHSN for MRSA bacteremia and C. difficile using our LabID event, which is a laboratory-based detection of a proxy measure of infection. And we'll also start looking at more process-related measures for healthcare worker flu vaccination and some data to be determined, to be finalized later in ambulatory surgery centers and other outpatient settings. So these requirements continue to develop, and facilities are reporting more and more data to the system because of these requirements. As you can imagine, we've seen quite a spike in enrollment recently in NHSN. This is our growth curve. And starting from January 2008, on the y-axis you can see the number of facilities that are enrolled in NHSN. January 2008, we had about 1,000 hospitals reporting. You can see over the course of 2009 and 2010 gradual increases as our ERA funding went out and states got facilities engaged in NHSN reporting. But you can see two big spikes where I have those red arrows, and you can imagine that in late 2010, many facilities who weren't in NHSN enrolled to be ready to comply with the requirement to report CLABSIs from their ICUs. And you can also see another spike that's happening very recently because of the outpatient dialysis reporting requirements. So as of today, we're at 6,900 facilities and counting in terms of facilities that are actually reporting data to NHSN. So we're on a very, very quick growth curve. So why use NHSN? The obvious answer is because CMS tells me to, because my state health department tells me to. But there are other reasons that we think it's a good thing. The application is free and it's maintained here at CDC. We also provide a wide variety of training and user support functions. We have a training webpage that provides training on surveillance methods, how to identify cases, how to enter the data in the system. We have self-study tutorials with interactive quizzes for many of our infection events to help infection preventionists learn about what they're looking for. And we also do a lot of training with local APIC chapters and other organizations where we can go out and provide training to a wide variety of users in the field. Recently, we've been starting to tape those. So if you go to our website, which I'll show you later on our training page, we have links to webinars that have been recorded where our expert infection preventionists have provided training that our users can go back and refer to over and over again. I mentioned user support. We have an NHSN@cdc.gov mailbox, and I'll keep coming back to that mailbox, where pretty much any question about NHSN can be answered. We have a staff of about 10 to 15 people who man those emails, and we are in constant communication with our users. An important point is that NHSN uses standard definitions. It gives us a national standard that all facilities reporting have to follow to make sure that we have a level playing field when we're reporting these HAIs. NHSN is prospective, active surveillance. Infection preventionists are going on the floors and trying to find infections in real time. We're not doing a retrospective review of cases after the fact. Something that's very important is that analysis tools are built into NHSN. An important part of surveillance is not just reporting. You don't do surveillance for the sake of doing surveillance. You do surveillance to see what's going on, to look at your data. We've built in some analysis tools that users can use to immediately look at data they've entered into the system to identify how they're doing. And they can use that tool, the analysis features that we have, to assess how they're doing compared to the rest of the country. We build in comparative rates. and rates that look at performance over time, so a facility can compare their performance from one quarter to the next to see how they're doing. And we'll get into that a little bit here. I want to give you a bit of a tour of our analysis feature and our aggregate national data. All the data that comes into NHSN is published every year, and the citation for this paper is in the bottom left corner on this slide, and the American Journal of Infection Control is where the annual report's published. It's also on our website. What I'm showing you here is a table from the report about central line-associated bloodstream infections. We take all of the hospitals that are reporting, and we look at the individual locations that they're reporting from. Many of them are reporting from their intensive care units. If you look at the red box on this slide, what I've done is show you our aggregate data for surgical critical care locations. So all the surgical ICUs in the country that report to NHSN, this is data from 2009, it's a little older. In 2009, there were 223 facilities that reported to NHSN from their surgical ICU. They reported 817 central line-associated bloodstream infections. We give the number of central line days that were reported. That's our denominator. You have to be on the device in order to be at risk for the infection. And what we do is we produce a pooled mean. You can see in the column in the middle of the slide. I'm not sure if you can see my arrow or not. But under the pooled mean column for the surgical critical cares, you have a 1.8. So that translates to a rate of all the data that's been reported from surgical ICUs. We saw a rate of 1.8 CLABSI infections per 1,000 central line days. So that's our national benchmark for 2009 for the entire country in terms of data that went into NHSN. In the last 5 columns, you can see our key percentiles, and what we do for those is look at the rates and put them on a distribution across the entire country. And just to illustrate that, if you look in the very last column for the surgical ICUs, you see a 4.2 under the 90% column. And that tells us that 90% of surgical ICUs that reported to NHSN in 2009 had a rate lower than 4.2. So facilities can kind of look at where they fall on the distribution to assess how well they're doing. So this is a screenshot from the NHSN application itself. Having the data in aggregate for the nation is great for benchmarking and putting out reports, but putting that data in an actionable form for facilities that are using the system is what's really important here. What I've shown you on this screenshot are all of our canned reports for CLABSI, for central line-associated BSI. We provide users the ability to spit out all of their infections in a line listing or a table, just listing all of the infections they identified. They also have the ability to produce output graphically in bar charts and pie charts. And the important things I want to cover with you today, the 2 reports to introduce to you, are rate tables and SAR reports, and we'll talk more about those. Those are in the red boxes. I want to draw your attention to the fact that we have 2 buttons on the right side of the screen there, a run button and a modify button. The run button is there with our preset parameters, so somebody who's not familiar with the NHSN tool can just simply click that button, have a report spit out, and they at least have some data that they can share and use to assess how they're doing. We also have a wide variety of ways that facilities can modify reports by time period, by different selection criteria, different filters they might be interested in, and they can do that by clicking on the modify button, just to illustrate that we have many options for our users. The measure that many of you are probably familiar with because it's on Hospital Compare is what we call the standardized infection ratio. And I think in healthcare, most people are familiar with these observed to expected ratios. And we're calling ours a standardized infection ratio, or SIR. The SAR looks at the observed number of infections reported by a facility divided by the expected number or predicted number of infections in a facility based on our national benchmarking data. So if we go through each piece of this equation, our observed number of HAIs in NHSN are pretty much that. The number, if they put 5 CLABSIs into NHSN for a year, the observed number is 5. What the system does with its calculation scheme in the background is it'll automatically look at the types of locations that are reporting in this facility, and it does a calculation to see how many infections we would expect if this facility was performing as well as the rest of the country. So when you think about an observed to expected value, we do some division. If we do a division and the number that we get for the SIR is greater than 1, the take-home message is that an SIR greater than 1 is that we have more infections in our facility than what we would expect given our national data. The converse is also true. If we have a smaller number on top than the bottom, we get an SIR that's less than 1, and that would tell us that we had fewer infections in our facility than what we would expect given our national experience here at NHSN. What we do is, as I mentioned, we calculate this on the backside in NHSN for our users. They don't have to do any of these calculations on their own. They click a button and get a report. And the screenshot in the top half of this slide is a picture directly from NHSN. So what this is looking at is we see org ID equals 10018. This is the hospital ID number within the NHSN system. I do want to point out that this is a fake hospital in NHSN that we maintain for testing purposes, so don't let the data alarm you. In the first half of 2011, what this data is showing us, in the third column, it's telling us the facility reported 17 central line associated BSIs for the entire facility, all the locations they report from. In the column with the red box in it, under the SIR, we do a division of the 17 infections that they reported versus the 3.7 in the number expected column based on the national data. When we do that math, we look at our observed number to the calculated expected number. Our SIR is 4.5, which tells us that this facility that we're reporting from had about 4.5 times more CLABSIs than what we would expect based on our national data. That's at the facility level. We also give facilities the ability to look at individual locations so they can see where they're performing well and where they're performing more poorly. They might be doing perfectly fine in their ICUs, but they have a problem in their wards. In this example, I'm showing you that this facility is actually reporting from 3 different locations. And NHSN is going to drill down and take a deeper dive and look at the overall, the individual locations reporting to the system. So in the first row, we show a 71 ICU location. In the second row, we show a MICU or medical ICU location. In the third row, we show a surgical ICU. So what the system does, and you can show you in the red boxes there just to briefly point it out, it produces an SIR value for each of those individual locations. You see that those are both very, very high, 4.9, 5.5. So their SIRs are telling us that they have significantly higher infections reported than what we would expect for those 2 locations. If you look at the SICU in the months column, it's showing us the number 1. So the SICU only reported for 1 month, but we know they didn't have any infections. So maybe they just started reporting, they're doing a better job. By looking at this location table, we know where we might want to focus for a prevention effort. So let's say we do a prevention effort, and we're interested in looking at how we are doing both from quarter to quarter as well as how we're performing against the nation. It's important that we dig even deeper and look at actual rates. So the SIR is a summary measure, but we also have the capacity to look at rates of infection. So for this screenshot, I'm showing you the medical ICU for this hospital. And in the first row, I'm showing you the first quarter of 2011. In the second row, I'm showing you the second quarter of 2011. So what this slide is doing is calculating a rate. In the first row, this facility identified 4 CLABSIs in their MICU in the first quarter, and they had 240 central line days. What we do is we standardize that to a rate per 1,000 central line days, and that's what's in the box with the red column and the red text above it. Under CLABSI rate, it says 16.667, which tells us that for the first quarter, this hospital in their MICU reported a CLABSI rate of 16 CLABSIs per 1,000 central line days, which is very high. In the next column over, the first yellow column, underneath the blue text that says National Benchmark Rate, this is where we plug in our aggregate data there. This is one of the value adds for NHSN. They're doing a real-time comparison of their data to the national data. So we know that for medical ICUs, the national mean rate is 1.6. Our rate is 16.6. So what NHSN does is it does a statistical test between our rate and the national rate, and it provides you a p-value in the next column over, which I won't get into here. But obviously, just by looking, you can tell that our rate of 16.6 is significantly higher than the national mean of 1.6. That tells us that we're not performing as well as others in the country. In the very last column, I also want to point out in the green text the percentile value. What percent of other facilities reporting have a rate below ours? In this situation, of course, it's 100. So everybody else who's reporting has a lower rate in their MICU. We're the outlier here. But this is the kind of information that a facility could get out of there. If we look at the 2 lines compared to each other, in the our rate box, our rate has gone down from 16 to 8, so we can see how we're performing from quarter to quarter, maybe if we put in an intervention, but we still see that our rates are higher than the national and pooled mean regardless. So thinking about how we can use NHSN for tracking performance, we know that the SIR is a measure that's being reported on Hospital Compare, and SIRs are great for looking at risk-adjusted overall facility summary statistics. We know that we can get the SIRs at a very granular level to target areas that are performing a little less well than others. But we also think that's important to look at rates, because the rate table output will help you look at trends from quarter to quarter. You can also use the rate table to look at the quote-unquote exposure burden. How many devices are you using? For CLABSI, how many central lines are in? How many urinary catheters in for CAUTI infections? What if we input an intervention? We try to get people off the Foleys sooner. Our device rate goes down. If we decrease our device rate, what happens to our infection rate? So we think that it's very useful data that's in the system to assess how well interventions are going. And again, analysis reports are very, very modifiable. And we have a wide variety of training materials that we're trying to centralize in one place on our website about analysis. And we'll touch on that again in a second. The last thing I want to mention really quickly, because it is a question that we get fairly often, is what are we doing in terms of electronic reporting of data to NHSN? Here is a kind of a schematic of how traditional NHSN reporting has been. In the top left corner, you see a pile of paper records. In the bottom left corner, you see a pile of disparate electronic data sources who don't know how to talk to each other. The IP uses a manual process to dig through the paper and the electronic systems to fill out a paper case report form, collect the different required information for NHSN, sit down at her computer, log into the system, and manually key the data in. At that point, it's sent to the NHSN server and served back to her so she can do analysis or share data with CMS or other entities. What we've done so far is to create an electronic solution for reporting data to NHSN using a Health Level 7 standard called CDA, or Clinical Document Architecture. This is usually mediated through an infection control vendor system, systems like Theradoc, Safety Surveiller. There are a wide variety of them. That system is an aggregator of lab data, pharmacy data, ADT data in one place. We've published file standards that these vendors can use in their systems to create files that can be manually exported from the vendor system and manually imported into NHSN, thereby reducing data entry burden to the infection preventionist. Where we'd like to go is a fully automated process, and we're piloting some automated processes this spring. We're excited about the direction this is going. We know that as more and more facilities move to electronic records and data sources that can talk to each other, we need to get to a point where we can use automated processes to both complete required forms, but also identify cases. We'll express these reports in a standard format, automatically send them from the facility system to the NHSN system, and then present them when the user logs in for verification and analysis. This is where we're going. With all the money and attention out there for health IT, we know there's a lot of interest in this, and we're looking forward to working with our partners, both at vendors and facilities, to kind of get towards this goal. I want to leave you with some resources. I've put a bunch of websites on this slide for you for future references. Our overall CDC HAI website is the first link. The second link is the NHSN homepage, and there's a wealth of information in there. I've provided 3 more sublinks to that page and the following bullets. Our resource library contains FAQs, manuals, and guides. Our training website has a wide variety of interactive and didactic training materials. And if you're interested in learning more about electronic reporting, please use that last link for our newly updated CDA page. Our user support mailbox is nhsn@cdc.gov. If after this webinar you have questions about analysis or how to use the system or what we do with the data, by all means email us there. If you have questions about electronic reporting, I've also included our CDA box there. So nhsncda@cdc.gov is where you can get in touch with us with your electronic reporting questions. So I'm going to wrap up and turn it back over to Chuck and Kyle.
Thank you very much. Really appreciate it. And I know Tom Knight is still on. Hopefully he has to leave right on the hour, and so we'll move up our reactions to Tom Knight if he is on. I see that we've unmuted his phone. Tom has been a terrific patient safety leader in San Francisco, multiple sites. He was the leader of safety and quality at Methodist Hospital in Houston, Texas, and has recently moved to Austin, Texas, where he's the Chief Medical Officer for the St. David's System, longstanding advocate and a real frontline fellow who also has led some initiatives in Houston that have really kind of broken some new barriers in reducing infections. Tom, do you want to give us your first reaction, and then we'll go to Steve Mayfield?
Okay, thanks, Chuck. Yeah, just, you know, it was very, very exciting to see the NHSN presentation because, you know, more and more, so much of our measurement has been fraught with error, especially in quality and safety and large confidence intervals. And, you know, central line bloodstream infections being one of the, and catheter-associated UTIs being 2 of the most important health problems we face in hospitals, but the actual measurement of them being traditionally from claims data data. So it's very positive that we're moving towards, better measurement. So, I think my staff sometimes feels like half the time they're working on the real stuff, and half the time we call it chasing windmills, kind of in a Don Quixote, with some of these measures that really aren't, really don't measure accurately the underlying safety problems. So I think my first reaction is that's a very positive kind of development, and I hope that we can more and more move to the issues that are most important to patients, that cause the most harm, and that we have the most tools. The other way I would react is, there's a lot of exposure of the problem right now, and it's almost exposure fatigue at times when you get out on the front lines, and I actually go out in our hospitals and do rounds every week, and so, I think more and more we need to be pointing towards solutions and tools and sharing not just the details of accidents and issues, but also tools and ways to improve. So I'm going to have to leave with that. I've actually got to go to an NCQA conference on diabetes recognition. So, but anyway, those are my initial thoughts, Chuck.
Thank you very much, Tom. Really appreciate it, and good luck in Austin. I'd like to now invite Steve Mayfield. We're really pleased to have Dr. Mayfield as a speaker today. He is a current Vice President for Quality and Performance Improvement at Hoag Memorial Hospital Presbyterian. We know him nationally because he has had a wonderful impact through national initiatives in performance improvement. He completed his doctorate in health administration and leadership at the Medical University of South Carolina, and MBA from Emory. He also serves on the board of the California Hospital Patient Safety Organization, has been a board member of Baldrige, is a black belt certified Lean Six Sigma leader, and been a faculty member on that. So he has the wonderful combination of terrific training and what we all aspire to learn, but also as frontline leadership at one of our community hospitals here, over 400-bed hospital in the community where I live. Steve, your reactions to, if you want to maybe start off on, from the NTSB type approach, health IT, and then also what we have heard from our leaders at CDC.
Thank you, Chuck, and for that very wonderful introduction, and my commendations to the wonderful speakers this morning. And I'll bridge first on what I just heard Dr. Knight talk about when he mentioned exposure fatigue on the front lines. We aren't suffering from a lack of data. We are suffering from a lack of the right data. Our staff are inundated with more and more data, and one of the arts for us in leadership is how do we winnow down to a smaller set of useful data that they can then turn into solutions. And so I think that was the springboard that I was going to jump on with Dr. Knight, and that is I'm really interested in how do we take this useful information and then turn it into solutions that improve care. And I've been struck by what is the credo at WellStar Health System outside of Atlanta, and a few years ago they redesigned their whole credo, and it's now don't hurt me, heal me, and be nice to me. And it just really resonates with me that the first thing is don't hurt me when we have this sacred trust when patients come to us, and how are we going to make the system safe for them? We can't have quality without safety. But having said that, the real question is how do we embrace the tenets such as the NTSB approach, which I think is an outstanding concept in which we would get interested parties who have these skills from different areas and different hospitals to, descend on a particular event that has occurred and learn from it and turn that into a lesson for others. One of our opportunities has to clearly be to create better detection systems for potential failures. We're pretty good at detecting the failure after it's occurred and doing root cause analyses and other interventions that give us the opportunity to, analyze it in great detail. We don't share those stories very well, but we need new systems that are robust and have the fidelity to sense the opportunity for a failure before it occurs. occurs. And that's, I think, to me, that is going to be one of the frontiers in healthcare that we're going to have to expand. And then finally, the solutions. We have got to create an environment in which the providers realize that it's not about just my individual competency, which is how everybody's trained. It's about how do I work in a team environment. And we don't get much training in that, and that's a fertile ground for us to cultivate and sprout these new systems that are going to help us be better. And I think we have appropriate tools if we can embrace them on a larger scale, things like ISO 9000 that creates a quality management system in which we standardize so many of the basic activities and processes so that we remove those obstacles from the practitioners, and they're not draining their cognitive capacity thinking about basic things. And finally, if we put what they need, where they need it, when they need it, we can really improve the robustness of the system. And linking to some of the HIT that I heard earlier, what we need includes not only the materials, equipment, and supplies, but the correct information to make the appropriate decision. And so I believe that's where the HIT platforms can really propel us to a higher level of safety. And I'll stop there, Chuck, and hand it back to you.
Great. Thanks, Steve. That was rich commentary. I'm going to go back to John Nance and build on what Steve just said. You and I, and you, because you many years more flying time and hours in the cockpit and much more robust training and experience, but having the ability to have the early warning systems and indicators that we have when we know we're heading into either rough weather or we have systems issues that we really need to address, we just don't have. We're flying hospitals blind and looking through the rearview mirror, whereas we in airplanes have color radar and indicator lights and system issues, and the leadership practices and technologies have been refined to really, as Sully says, when I spend time with Sully, he landed on the Hudson because the systems provided him enough support that he could be innovative and have to do things that weren't in the book, because as Steve said, it didn't draw off the cognitive performance, which is probably our biggest, our weakest link is behind the yoke in those of us that are pilots. John, maybe just kind of react to, don't you, you and I believe that we've just scratched the surface of what we can bring over from aviation. I think Steve really nailed a number of those issues.
I think the most important aspect here is that it's not just aviation, it's nuclear power generation, it's a whole bunch of other industries that have figured these things out. And we need to learn from all of them. It is appalling to most safety professionals in high reliability organizations that are also potentially high risk, like aviation, that healthcare has never had this sort of approach and has never really gotten to the point of even talking about a safety buffer. We had a big debate in the middle of the 80s on safety buffer with one of our leaders in the nation, Elizabeth Dole, who was Secretary of Transportation. She said, well, safety buffers, it simply doesn't make any sense. It's either safe or it's unsafe. Nothing could be further from the truth. There's a point at which something goes wrong or could go wrong, and between that point and the point at which it's irretrievable is the safety buffer, and we need to build a safety buffer into healthcare, and the way you do that is by prospective and by not reactive, but by looking forward and saying we are going to take everything we can possibly get to figure out what the trends are and to figure out where the problem's going to be long before they metastasize into an accident or an incident, because at that point you have no buffer.
So these are the areas that we want to address in our summit on health information technology. It's a patient safety summit again, April 27th. We'll have 8-minute presentations and then a lot of interaction and questions from our research test bed. We represent 3,100 hospitals across the nation, and now we have folks in Europe. And we'd like to really have some robust questions regarding how we take, where we know we need to go and where these systems don't exist, what we need to really do. And I come back to David Klassen to maybe react to what you heard from CDC, and also us connecting the dots and maybe paint a little bit of where we need to go forward before we then go to Vivian Lauderdale and Jennifer Dingman. David?
As we were writing our new Institute of Medicine report on patient safety, the issue of why do other high-risk industries have put in programs like this, healthcare seemed to stand out uniquely as the high-risk industry with no approach like this, no NTSB, no prospective approach. So, John, I would just echo what you said. We were kind of stunned as we looked across the industries how little had been done in healthcare compared to other high-risk industries. In addition, I think the CDC presentation is really superb. I think it shows how we can develop an effective measurement system for one aspect of patient safety. And interestingly enough, I'm a practicing infectious disease doctor. I would say that in our studies of safety that we reviewed at the Institute of Medicine for this most recent report, the one area where we had seen improvement was in things such as CLABSIs and ventilator-associated pneumonia. They were clearly far less frequent than previous studies have shown. So I think the proof is in the pudding in that area. But the problem is those areas of improvement are just dwarfed by other problems that lead almost a third of all hospital patients to still experience harm. So we have a long way to go, but I think the infectious disease approach is a reasonable one to emulate.
And I'd like to remind everybody in the right lower hand part of your screen, we have 3 polling questions. First, would a standardized blinded report on common harmful events be useful to you or your organization? Clearly, if we were to create a mechanism for what John's vision of a red cover report that is the output of what an NTSB for healthcare could be, regardless of whether it's an agency, public, private, or whatever. Secondly, would you like a webinar demonstrating the methodology applied to some specific, really common adverse events that have captured the news that occur all the time? And third, would you like a webinar providing additional details with a deeper dive on the NHSN initiative? Really a great job from CDC today, and we'll go to them after we go to Vivian Lauderdale and Jennifer Dingman. It's a real pleasure to introduce Vivian. We asked Vivian to be we're going to start having 2 patients, 2 family representatives, 2 non-clinician representatives on our webinars, and Vivian has been a long-standing editorial leader with us on the Journal for Patient Safety. But I think more importantly is every Saturday morning, every month, we have a group of patients and families who have lost loved ones who convene and talk about what they can do to help support us in healthcare. So she has the rich experience of seeing both sides. Vivian, your reaction to what you're hearing today, and Vivian comes to us with a strong background in quality systems as a certified person that helps organizations with quality as a technical writer, and then also very actively involved in helping us with the Journal of Patient Safety. Vivian?
Thank you, Chuck. Well, I must say, though, I work in patient safety now, and my entire career has been installing quality systems in pharmaceutical and medical device and clinical chemistry laboratories. Today, I'm representing myself as I look in the picture, which is me in my garden, being a grandmother. So I'm a consumer today. And I must say this webinar has just been really enlightening. Having Sully present his thoughts about how important evidence-based root cause analysis is and the importance of leadership is extremely important from my viewpoint. And then John Nance proposing a blue cover report for hospitals. How shocking that that doesn't exist. When I've given people your article, Chuck, the NTSB, and also Dr. Klassen wrote about an NTSB for healthcare in his latest article, people are absolutely shocked, especially pilots that I know. They're just shocked that that doesn't exist for the hospitals. Dr. Klassen, thank you so much for discussing the IOM report. And what I thought was most important that you talked about that I had never really heard before was the importance when an electronic system is shut down and turned back on, that there's not really a testing procedure for whether it's working or not. that seems amazing. And then Paul Malpidi, that was really great information on NHSN, how that works, and the SAR reports. It just seems like hospitals need to be compared with each other and really know how they're doing and really have the metrics to be able to see when different procedures that they have are allowing them to improve. So we as patients know there's a problem out there, and we are really excited that folks from different fields are putting their expertise into solving problems, and I think we can all feel better for the future that we're taking a look at these problems and solving them. So thank you very much.
Thanks, Vivian, and we appreciate your steadfast support of our consumer side. Vivian was also instrumental in helping with the National Quality Form Safe Practices program. Jennifer Dingman, Jenny, would you please give us your view as an activist, as a very positive activist out there, networking with folks that are trying to get their messages regarding patients and families into the boardroom?
Well, I am just so amazed by today's webinar, and I'm really excited about the future to hear everything that I've heard today. I have strongly supported a National Patient Safety Board for a very long time when it was first mentioned, I believe, by John Nance many years ago, and I've always wanted to see this happen. So for me and for my colleagues, this is a possibility now that this might happen in our lifetime, and I'm really super excited about that. With regard to the HIT, I learned a lot that I didn't know about the electronic medical records, and I think that this is a great opportunity for us to really track things with the new electronic medical records and also involve the patients and families. More than anything, we really need to consider putting more patients and family members of patients on boards throughout hospitals, on committees throughout hospitals, and activate them to help and share their ideas to help make your facility safer. I'm just so thrilled to hear what Dr. Klassen had to talk about today with regard to the IOM report. There's just so many great things happening, and of course our government and collecting the data through the Health and Human Services and CDC. I'm really excited about that, and I think if we could just kind of spread that like a big umbrella, the things that are going on in our government throughout the medical industry, I think we could really do great things. Lastly, I just wanted to share the fact that we are all patients, but we're also consumers, and consumers, you know, must be savvy, and it's very unfortunate that the folks in our day that want to be patients really can't do that anymore because of the complexity. And I just want to thank each and every person on this webinar today for being here and putting those patients first and thinking of those patients. And hopefully someday we might be able to have a real peaceful way of sharing healthcare experiences and positive outcomes, thanks to people like yourself.
Great. Thank you, Jenny. So I have a couple of questions immediately from our audience, but I'd like to go back to Paul and Arjun and have them describe, for those that are out there and the members of our test bed that are out there, how do you see the evolution of the NHSN and these other decision support systems like Theradoc and the other what we call automated infection mitigation systems, these systems that help you analyze what you're doing and then have outside support? How do you see those evolving? Will the NHSN actually kind of take the place of those, or where's the power alley for the long-term future?
Right. Thanks, Chuck. And unfortunately, Arjun had to step out. Actually, he's rounding. He's on service. So I was hoping he'd be able to put together some big-picture thoughts, but he won't be able to join us. Sorry about that. In terms of your question about decision support systems and their relation to NHSN, as far as we see NHSN, we see it as a reporting system where people can use data that they enter in there, regardless of how it gets in, to assess performance and try to improve patient safety. I don't think we'll ever have a role within NHSN itself for clinical decision support. With that being said, we are working very closely with a lot of vendors. You know, this CDA, or electronic reporting, started back in 2007, 2008 with a handful of vendors through a pilot. I work very closely with the group of vendors that we work with, and that continues to expand. So there's a lot of interest out there in the vendor community in terms of putting together standard files in their systems that infection preventionists in the field can use to send data that they're already putting into their decision support system to spit it over directly to NHSN, and we're trying to make that a little more seamless. I think that, you know, the sky's the limit on these kind of collaborations. We want to get to a point where a user at a hospital in a medical record can just click a button and have files go from the medical record, detect the infection events automatically, if we can ever come up with some standards for that, and just seamlessly move it over to NHSN. We're not there yet, but we're working towards getting there.
Great. Dave Klassen, I'd like to go to you. Thank you very much, Paul. And Paul is, again, an epidemiologist at CDC, leading the team that really helps support this initiative. David Klassen, let's go back to you. And from the very practical standpoint of, let's say we've got a fresh new patient safety officer or a new chief quality officer for a typical 300-bed hospital. What you have a great insight as to what the global trigger tool has developed and where we understand our underreporting is. What would be your top 5 areas that a brand new safety officer should really be concerned about now that many of these things have evolved? What are the adverse events that you think we really are missing because we're underreporting, fearful of reporting, or just not capturing?
Yeah. You know, what I'd say to anybody starting that position is, rather than doing what the national authorities tell you to focus on, the first thing you need to do is a deep dive at your own organization. You really do need to know where the harm occurs in your organization, because it really varies from hospital to hospital. And having done the global trigger tool as a manual deep dive at many organizations, and now having automated the global trigger tool within commercial EMR systems that allow us to study harm in every patient in real time, I'm always impressed that hospitals find things that if they read the national tea leaves, they would miss completely. So I think a deep dive at your own organization where your harm is absolutely critical as a first starting place. The other thing I think that obviously has to be done is creating a measurement system that provides information that's of value to people on the front lines of care. Unfortunately, in safety, we've been driven by creating measurement that's reporting stuff outside the organization to national authorities and others. That doesn't help the person on the front line actually improve the care for that patient in the room. And so I think creating measurement systems that actually help people on the front lines of care is absolutely critical. Unfortunately, that's not what we've done. And then the other issue I think is absolutely critical is we have to address culture at the front lines of care. Without doing that, all the best measurement systems in the world and all the best content in the world will not lead to better care for patients. So, you know, Chuck, those would be my top 3.
Thanks, David. Great advice. John Nance, coming back to you. You've gone through this in your career. You and I are kind of the old guys that have been around a long time, and you saw what happened from the Boeing the Boeing report, which I'd like you to just give a snapshot. It's in our article for those that want to read more detail. But the CAST initiative that dramatically dropped the aircraft adverse events, more than 80% was a cross-industry approach, just the way David is describing on kind of where are your problems and then internally being able to address them coupled with culture. Do you want to just maybe give us an insight? You can do it. You really can do it, and we did it in aviation with pilots and airlines and the FAA.
Well, absolutely. David is so absolutely dead on. You've got to look in your own organization, know where the harm is, and we recommend constantly that leaders do an immediate 360, which is painful at times, but that's how you begin the process. In aviation, one of the things that happened, this was back in the 80s, Boeing did a major study, and they came out all literally with their jaws on the floor when they realized that with the projected growth in commercial air traffic over the next 25, 35 years, if we stayed as an industry at the same level of safety, relatively speaking, we'd be dropping a couple of airplanes a week, and there really wouldn't be an industry because nobody would trust us. It became so horrendous, the projection of these figures, that it led to this CAST initiative and a lot of others. It was a wake-up call that was as Rob-Nagagian and important as the wake-up call provided in 1977 by the crash of 2 jumbo jets in Tenerife. But the Boeing study and what happened afterwards, the yet serious nature of that, focused us on where the focus should have been, which is human failure in a human system. We try to dehumanize our systems all the time, and when you do that, you push little boxes around and you push tactical programs around, and you wonder why it's not making a difference. We have to, if we're going to interdict patient safety problems to the point that we can get to zero, and we can get to zero. Absolutely. We've proven it in several industries, including aviation. If we're going to be able to do that, the first thing we have to do is learn why we fail, how we fail in each particular, and the fact that these are human failures in a very complex adaptive system, and they can be handled. They can be handled not by saying that we're going to eliminate all human failure, but by saying we're going to minimize that human failure, and we're going to create systems and communication and relationships and the alacrity of understanding that's necessary to put things in place to make sure that the failures that do come leaking through, we're going to catch each and every time, which is basically the essence of teamwork.
Fantastic, John. I'm going to take the last question to Steve. We're really honored to have you on, Steve, and honored to have you out here in California. You come to us now having really undertaken a deep dive at understanding our national culture, but you also are at a frontline hospital facing all the barriers that everybody faces today. I know your board, wonderful people. I know the community. I know, where you are. You really are at the tip of the spear now in the front line. You've got the training in formal training in performance and human performance and performance improvement and that kind of thing. What advice do you have for us now as a guy that has a view both as the big picture and at the front line and the tip of the spear? And we'll ask you that question, then we'll go to Frank Guilleteau, and he's going to address an initiative very quickly for a minute or two to follow up on Jenny's comment on getting patients and families in the boardroom, which is something that will be incentivized by your payers, and we'll give you a little bit of a hint of that. But Steve, you've got a great big view. You've got the front line view. What advice do you have for our safety and quality leaders on the phone today?
Well, for the quality leaders who are in the trenches, you've really got to get the buy-in from the board. It starts at the top. There needs to be a coherent vision about what level of preventable harm are we going to accept here in this organization, and that needs to be articulated, and hopefully it's going to be to drive it to zero, and it's got to be about we want to eliminate harm. We'll reduce error along the way. And then the next thing is once you've got the vision, then what I found to be successful is to get some quick wins with frontline staff through tools that help standardize their processes by removing obstacles, and things that come to mind are Lean and Six Sigma. If you go in and you do a Lean project with 5S and you make it easier for nurses to have what they need, where they need it, when they need it, they get to spend more quality time with the patient enjoys it, the physician has what he or she needs when they come into the room, you improve the throughput, you get a financial gain, a satisfaction gain, you get a workforce morale gain from that, and then you can start pointing to that. And you have to tell the stories. And one of the things I say is make it Hollywood, Hospital Hollywood. Get digital or video clips and show 8-minute clip. Follow that team through what they did and start showing that internally to the organization and build your own repository of success stories. And then from that, those drops, those little ripples, they begin to spread out. And then start building internal capacity. Here at Hoag, we've created a center where we're teaching Lean and Six Sigma and producing green belts, not for the goal of producing belts, but rather to put these tools in the hands of supervisors and frontline staff so that they can improve their work area. Turn it back to you, Chuck.
Thank you, Steve, and we'll be inviting Steve to be a future presenter because we've got such a great resource who's joined forces with us here in California. I'd like to turn things over to Frank Guilleteau. Frank is our Chief of Staff. He is a wonderful leader behind the scenes in our Austin headquarters where this webinar actually, all the infrastructure and Kyle Kemp and Carrie Brown and a whole host of folks, Rod Reyna behind the scenes that Frank leads, put this webinar on. And Frank is going to take just a minute or two to describe a new program that we've developed as a response to the need and the incentive that CMS is going to provide to get patients and families to come in and tell those stories that Steve just mentioned. Frank, take it away.
Sure. Thank you, Chuck, and we're very excited about this project that we've undertaken here at CMIT, and it's kind of our gift to the community, and we're highlighting it in every one of our webinars moving forward because we really want the community to be aware of it. And as Chuck said and Jenny touched on, which is the work that we're doing around leadership and board engagement has really kind of giving us some feedback that these organizations are, as they mentioned, increasingly being asked to bring patients and patient advocates in the boardroom, and with that comes a significant challenge. First of all, where do you find these patient advocates? And second, when you bring them into the boardroom, how do you ensure that the content and the message that's being delivered is appropriate? So we went to our research test bed and our patient advocates for suggestions, and they provided us with this framework, which effectively is an online tool that we refer to as SpeakAlink. And SpeakAlink addresses really kind of two customers. One, first of all, is the speaker who has a story to tell and is looking for a way of engaging local and national organizations to share some of their knowledge and experience beyond just the local network, and thereby contributing, much like Jennifer mentioned, to some of their knowledge that may be very useful to an organization that may have gone through some challenges. And then the second one is the seeker, so hospitals that are currently, or groups that are currently looking for stories that may inspire, but also stories that could give directions to that organization that are maybe following a certain initiative. So if you look, we have here is the slide of our website, and it gives you effectively two options. So if you're a speaker, you can enter your profile, your background information, and essentially register. And if you're a seeker, thereby an organization looking for a speaker, you can click Find a Speaker. And if you click on that, you will get a search page that provides you different fields, such as keywords or speaker names. If you're looking for someone like John Nance, you could enter it in there, or look by topics or target audience, or even in some instances of folks put their fee range. And when you click on the search function, you get a result page that gives you an inventory of the speakers or advocates that who are interested in speaking on that relevant topic. Since we've launched this, which is at the beginning of the year, we've been able to engage over 120 patient advocates that have signed up. So the map here shows kind of their distribution. And we're working very hard to engage regionally because we realize that hospitals many a time are very interested in having national speakers, but also local folks that may have done some great work in that area and have a unique community perspective. So if you click down on one of them, in this case, we're clicking down on Alicia Cole, so you get a profile of that individual, her offering, what she's, her background. In this case, she's an actress. She has worked extensively in the area of healthcare-acquired infection, having experienced a challenge in her personal life. And you see across the top are a series of tabs that allow you to see other information, such as her biography, but also any recommendations that come from the prior work with organizations that she has done. And in this case, we know that, for example, Alicia Cole presented at the QualityNet, the QIO QualityNet. So she has extensive experience in speaking in front of large audiences, and that should, as organizations look at engaging her, provide kind of a certain comfort level. Contacting her in this case is straightforward. You just would input your name and your email, your organization, submit it, and you get her direct contact information, and you can engage and vet her if you're interested in working with her. So at this stage, SpeakAlink is really kind of a venue, but we're working really hard, first of all, to grow it, but also to develop educational programs that will help the speakers that have joined SpeakAlink enhance and expand their skills and make sure that when they go into the boardroom, they're well prepared. So in closing, we're very excited about this effort, and if you're on this webinar and you know anyone, even someone that doesn't have extensive experience that is interested in sharing their message, please give them the link to SpeakAlink. And as I say, you don't have to be a world-class speaker to be part of this effort. If you're a speaker, you can certainly ease into the venues that are offered to you, the ones that you're comfortable with, but the important part is you're growing this network, this community, and you're sharing stories that will inspire others and make an impact on quality and patient safety. So please join us. Again, it's speakerlink.org. Chuck, I'll turn it back to you.
Great. Thank you very much, Frank. And this is consultants, speakers, anyone, and also seekers, so those hospitals that are looking for somebody in their region to do so. There's no fractional charge or anything like that. We're trying to figure out a way to be able to have it at no cost at all, and maybe certify people to be screeners to provide them with the upcoming movies and other things. So there'll be a lot we'll try to do to help move this forward. What I'd like to do is I'd like to have our speakers just stay on after Jenny Dingman. We'd like to thank all of them, though. They're absolutely terrific. This is a recorded broadcast. We will have a word searchable document, a transcript, as well as you may view the slides, and the audio will be coupled to the slides so that you can watch it. And in future, we'll be porting all of our webinars into an LMS system so that people can asynchronously watch them as part of a more organized program. But I'd like to, again, keep our speakers on afterwards so we can do a little performance improvement cycle to see what we could do better next time. We'd like to thank all of them for their terrific job. And Jenny, would you please close us with, again, we want to open with a patient, close with a patient. Jenny, would you please close us?
Yes, what a great webinar we had today. Thank you, everyone, for being here. And I have a special request to everyone on this webinar. Please take what you learned today and share it with one or two frontline providers that weren't able to make it to the webinar. And I think that these folks really need to hear this, and I think it will enrich them and give them a great deal of hope for the future, and hopefully greater things are going to come. Thank you again, and looking forward to working with you all in the future. Thank you.
Thank you very much, and we'll end the webinar. Again, I just put up the final slide, February 27th. Our next webinar will not be on Thursday, it'll be on Friday, and we will broadcast from 10 a.m. East Coast time to 4 p.m. And a deep dive on many of these subjects will be undertaken by everybody on this call in addition to others. So thank you so much, and that ends our webinar. We're a little bit over today, but I really appreciate everything everybody had provided. Thank you. Have a great day.